know where everyone's coming from. Uh, Welcome, everyone. We're on a little early, so we're happy to have you. We'll give it about 5 more minutes, and then we'll get going with our webinar today and hopefully have some wonderful clinical pearls that we can share today. We're very excited about it. And we'll make some announcements as well as far as when the slides will be available. So for those of you, I'll repeat this again, but just for those of you who are here, we will have slides available and the recording will be up within 48 hours after the webinar. So probably before the end of the week, you all will have access to the slides from today's presentation as well as the recording in the educational tab of your account. And then I believe, JT, you guys are also going to be sending it out via email, or will it just be uploaded onto the educational site?
They usually send out a post-event email.
Yeah. So you all will be receiving this information hopefully by the end of the week. So and I am joined here with Maureen. Like I said, we'll have more of a formal introduction, but Maureen Pickle, who is one of our clinical science liaisons, she'll be moderating today's conversation. You might get some answers from her throughout today's talk, but feel free to type your questions into the Q&A box, and that way we can make sure we get everyone's questions and they don't get lost in all the chatter that can sometimes happen in the chat. Because I'll have a few questions I'll be polling the audience, and I don't want to have your questions get lost. So make sure you're putting your questions into the Q&A box. We'll give it a few more minutes and then we'll get going.
You're on mute.
Now you can hear me. Welcome. Those of you who have just joined us, we're going to get started here in about another minute. And we're looking forward to this topic, and hopefully we can have some good discussion today. I know this is a hot topic. And then JT, is there anything that you want to say here at the beginning? Any announcements, or do you want us to just do it?
You could just dive right in.
All right.
All right. We'll give it just another moment. And for those of you joining us, I'm sure most of you know Alicia Galvin by now, a registered dietitian and functional nutrition expert and clinical science liaison with Microbiome Labs. She is dedicated to empowering clinicians to help their clients achieve optimal health through personalized science-based nutrition strategies. With extensive experience in integrative and functional medicine, Alicia has worked in the field for over 15 years and specializes in complex digestive disorders, hormonal imbalances, autoimmune conditions, and metabolic health. She is co-founder of SIBO Academy, an online training platform that delivers evidence-based courses in the arena of GI health, and is mentored to colleagues. Alicia's expertise is regularly featured in national media, and her commitment to ongoing education and innovative holistic health solutions makes her a sought-after authority in the field of nutrition. And we're so lucky to have her join us today.
All right. Thank you so much, Maureen. And let's go ahead and get these slides up and we will get going. Well, thank you so much for those of you who are joining us live today. We're very excited to have you. And if you're listening to the recording, thank you for registering and for joining us in a conversation that I think is just not talked about enough. This is very excited about the opportunity to educate on this topic of women's health and especially the female microbiome, because it is such a critical hub for women's health. And I hope that throughout this conversation today that you, if this is a newer topic for you, newer information, that at the end of this, you see that there is definitely a correlation and there's such an important need for us to support women's vaginal health and the vaginal microbiome, because it truly does influence women's overall health. And so with that, we'll just dive right in and we can start our conversation. Please feel free to ask questions throughout the webinar today. If you could put your questions in the Q&A box versus the chat, because I'll have some questions for you. I'll poll the audience throughout the conversation today, and I just don't want your questions to be lost in the chitter chatter. So please put your questions in the Q&A box, and then we'll have a Q&A at the end. And Maureen will help in answering those questions as well. So she has extensive experience in women's health. So you have two experts here in the field, and we're happy to be educating you today on this topic. So to start out the conversation, I'm just curious, any idea, any thoughts on what these numbers mean? And you're probably thinking, well, this could be any number of things. It could be anything on the planet, but anyone have a thought on what the importance of 75, 21.9, and 80? And if you have some thoughts or hypotheses, feel free to just type them into the chat box, and I can see if anybody is able to guess what this might mean. So 75 is 75% of women in their reproductive years will have a yeast infection. So that's a lot of women. And so you're probably seeing those women in your practices. And if you're here today, it's probably because you have women and patients who are coming to you with these various complaints, or they have concerns. They might be coming to you with frustration. They might be coming to you with loss of hope. They might be coming to you with shame or embarrassment. And so when we think about the importance of these numbers and what they mean, it's also talking about just the numbers of these women who deal with some of these issues. 21.9 million is the number of women who would be diagnosed with BV. And then 80% of women will have a relapse, or up to 80% of women will relapse with BV even after undergoing treatment. So there's a place for us to look at, why is this happening? What are the conditions that are allowing for yeast infections and BV to not only come about, but also to be resistant to treatment? And what can we do about it? So this is the agenda today. I'm not going to spend a lot of time on it because this is just telling you what I'm going to tell you. But here's some interesting information that I think is also very important to understand. And so women's health has not been researched very well. It's been grossly underfunded. And there's a historical bias in the literature, mostly towards preferring men in the research trials and as participants in the various research. And so a lot of these clinical trials that have been conducted, one, they're not really looking at women's health and women's issues specifically, because women are complicated. We have many more hormonal fluctuations than men. We go through menopause. We have fluctuations in our hormones and vaginal health throughout the month with our menstruation. And so we can't extrapolate the results of clinical research that might be biased more towards men and results that would be more related to men. And we can't say that that's going to necessarily be the same for women. And so we can do better than that. And this is an area, and luckily there's becoming a little bit more research in this field, but it's essentially a newer area that we need to explore more, and it's been underfunded for years. And with that, I want to then go into talking about the vaginal microbiome and talking about the health and the role of the microbiome in overall women's health. So the vaginal microbiome should be predominantly lactobacilli. Lactobacilli are our guardians of the galaxy, so to speak. They are the guardians of our vaginal tract. They are the ones that are going to produce all of these really wonderful antimicrobial substances, and they're going to produce lactic acid, and they're going to help to protect the vaginal environment from the invasion of pathogens. And so we want to have mostly lactobacilli species. And so with that, we want to have low bacterial diversity. If you've listened to our conversations, if you've heard us talk on whether it be at a private event or a conference or a webinar or in just conversations with maybe your sales rep, you know that we talk a lot about with the gut microbiome, lots of diversity. So with the gut, we want to have high alpha and beta diversity. We want to have lots of different types of species. But the conversation changes when we're talking about the vaginal microbiome. We want low bacterial diversity. We don't want to have a lot of species present in the vaginal tract. We want to have it a predominantly lactobacilli environment. And those lactobacilli, through the production of lactic acid, will keep that pH nice and more on the acidic side. So between 4 to 4.5 is considered optimal. And there are 4 predominant lactobacillus species that are found in the vaginal tract. We have Lactobacillus crispatus, we have Lactobacillus gasseri, L. jensenii, and then Lactobacillus einers. Now, Lactobacillus einers, we'll talk about that a little bit more. It can be associated with dysbiosis. It just depends on who else is there in the vaginal tract. So in and of itself, it can be a healthy species, but if it's in the presence of other microbes that are potentially opportunistic or pathogenic, then this type, or if you have a predominance of this type of species, it may not be as healthy. So the importance of vaginal microbiome balance is influenced by several environmental life factors. And I would wonder, and feel free if you have any thoughts in the chat, just type in some ideas, but what would be some dysbiotic risk factors? What would be some things that maybe your patients are doing that could negatively influence, or negatively or positively, but basically influence the balance of the vagina and the microbiome? Any thoughts of what some of those factors might be? Feel free to type them into the chat. Yes, smoking, douching, that can definitely, so hygiene, diet, use of different products, especially if they're scented, stress, thank you, that's definitely can be a factor. Hormones play a role. So yes, definitely all of the above. Yoga and those type materials or what you're wearing. So diet can play a big role, whether it be a really whole foods diet rich in phytonutrients, or whether it's a very high sugar, high processed diet. Hormonal changes, especially with estrogen and progesterone. We'll talk about estrogen in a minute. Sexual activity and sexual practices, the number of sexual partners for sure. Hygiene practices. So I saw some of you mentioning some of those hygiene practices, medications like antibiotics, and then stress. So how many of your patients do you have who have one of the, at least one, probably more, of these dysbiosis risk factors? Probably almost all of them are going to have at least one of these that could be affecting their vaginal microbiome. So I talked about hormones as being one of those things that can influence the microbiome. And when we think about what happens throughout a woman's lifespan, our hormones change, right? So in youth, when we're pre-puberty, we don't have a lot of estrogen, we don't have a lot of progesterone, we don't have a lot of hormones that are going to support the vaginal environment. One of the things that estrogen does is it helps to support glycogen in the vaginal tract. And glycogen is what fuels our lactobacilli. That's the fuel source, that's the food for these bacteria. So in our youth, pre-puberty, you can see that estrogen levels are low, so glycogen levels are low, and so that lactobacilli population is going to be low. So there tends to be a higher pH and a higher microbial diversity in youth, and then the same thing happens then postmenopausal. and through that perimenopause and postmenopausal timeframe, when those estrogen levels start to fall again, that's then going to decrease that glycogen, decrease the lactobacilli abundance, and therefore affect the vaginal pH. Now, during our reproductive and pregnancy years, we have nice, robust levels of estrogen, and so that's going to support that glycogen level. We're going to get higher glycogen, and so therefore we're going to have more food available for those lactobacilli to feed off of and then proliferate and therefore support the vaginal environment. So a woman's lifespan is going to affect, and that will change the environment of the vaginal tract. So this is just a picture here that will show some of what I was just saying. So if we have enough lactobacilli present, they're going to make these antimicrobial peptides, specifically things like bacteriocins and hydrogen peroxide, which are going to be able to inhibit or reduce the ability of those pathogens to survive in that vaginal environment. Lactobacilli will also make lactic acid, and so that's going to keep that pH nice and acidic in that less than 4.5 range. Whereas if we have a dysbiotic vaginal environment, so if someone does not have enough lactobacilli, maybe they have low estrogen levels, so they don't have enough glycogen, maybe they have many different dysbiotic risk factors present, that's going to then decrease those protective mechanisms, the lactic acid, the bacteriocins, the hydrogen peroxide, and so that'll allow these pathogens to invade, and that can then lead to different complications. We're going to talk about some of these in a minute, like BV and pregnancy outcomes, and then that's going to lead to these adverse events that we don't want to have in our vaginal environment, and that can affect the woman overall systemically. So vaginal dysbiosis can then lead to things like BV, bacterial vaginosis, vaginal yeast infections, urinary tract infections. Probably most of you are seeing these in your practices most commonly, but it can also lead to other pregnancy outcomes like premature birth or low birth weight, endometriosis, cervical cancer, pelvic inflammatory disease, fertility struggles, STDs, gynecological cancers, and toxic shock syndrome. Now, these are going to definitely be on the more extreme side of the spectrum. You probably are seeing mostly the top three, but you could potentially see some connection between a woman's vaginal health and some of these other outcomes. So a question I have for you, again, put into the chat, what percentage of your clients do you think struggle with one of those top three conditions, whether it be BV, yeast infections, or UTIs? Would you say 10 to 30%? And you can just type in like a yes or a number if you think it's 10 to 30%. Do you think it's 30 to 50%? Do you think it's 50 to 75%? Or do you think it's over 75%? So when I've asked this question before to different audiences, generally I'd say over. So if someone says over 75%, 30 to 50. So yeah, painful intercourse can certainly go along with this. 30 to 50. Okay. Yeah. So I'd say that's generally when I've asked this question to different audiences, it's about that 50%. I think most people are feeling like it's in that range. So it's a significant number of your patients who are struggling with one of those issues. But how do we classify it? So we just talked about how you have 4 primary lactobacilli that are considered healthy in a vaginal environment, but how can we classify these? And vaginal dysbiosis and the community state types is how we do this. So there are 5 community state types. The first state type is Lactobacillus crispatus dominant. And so this is considered one of the healthier community state types. It has a very acidic, less than 4 sometimes pH. It is also the most resistant to dysbiosis. So what this particular microbe is very efficient at doing is secreting D-lactic acid. D-lactic acid is very good at keeping that pH nice and acidic. It keeps the environment very stable. And so when a woman is menstruating throughout the month, they're not going to shift. They're not going to generally flare with like a yeast infection. That environment's going to stay very stable even during that time frame when they're menstruating. Because remember, you want your vaginal cavity to be acidic. And if you have that bleeding every month, blood is not acidic. It is more alkaline compared to the vaginal tract. And so between that and then also just the flow of the blood every month, that can shift and that can change. And so that's why some women might have changes and symptoms around their menstrual cycles as well. There can also be some hormonal component, but that can be another factor too. Type 2 is going to be L-gastrin predominant, so that's going to be a little bit more alkaline, so 4.4, but considered healthy. It's not as common, but it's rarely associated with diseases. And then you have state type 3, which is Lactobacillus iners. Now remember I said L. iners can go either way. And this is because L-iners does not make D-lactic acid, it makes L-lactic acid, which is not as effective at inhibiting these pathogens. And so if someone has a predominant state type of type 3, they can very easily transition to a more dysbiotic state, like a state type 4. And so state type 4 is when we don't have lactobacilli. It's when we tend to have maybe more bifidospecies, or it could be even having more opportunistic or more pathogenic microbes, very highly associated with things like BV, sexually transmitted infections, endometriosis, and miscarriage. And so we really want to try to avoid or intervene with this community state type because this is associated with poor outcomes. And then we have state type 5, again, not as common, but tends to have a more acidic pH of about 4.2 and is considered one of the healthier community state types. So what we're going for when we're looking at a woman's environment in the vaginal tract is we're looking for a state type 1, 2, or 5. State types 3 and 4, not so much, because they tend to be associated with more diseases and poor outcomes and health conditions of the woman. Now, the community state type can also be influenced by our gut health. And you'll hear us talk a lot about the gut-vaginal axis or the gut-vagina axis. And when we talk about probiotics and we talk about how is it that you take oral probiotics and affects the vaginal health, and that's because of the proximity of these different openings in a woman. So the opening for the anus, as well as the vaginal tract and the urethra, are all in very close proximity to each other. And so if a woman has gut dysbiosis, that can then lead to vaginal dysbiosis because of that translocation of certain pathogens, like maybe E. coli or staph or certain microbes, strep, that can go from the gut and into the vaginal cavity through just in the shedding of species. But also on the flip side, if a woman has a lot of lactobacilli present in her gut and in her stool, then that can then translocate and that can get into the vaginal cavity, and then you can see an increase in lactobacilli in the vaginal cavity. Community state types 3 and 4 are associated with microbes that originate in the gut. So part of that whole dysbiosis and having more diversity in the vaginal tract with some of those other community state types tends to go along with possibly some gut dysbiosis. So if someone has gut dysbiosis, then that can beget vaginal dysbiosis. So I have a question for you. How many of you are currently testing community state types in your practices? Are you running any vaginal testing? Are you looking at community state type? I'm just curious, you can just put a Y or an N into the chat if this is something that you have already started doing or are familiar with. So I'm seeing some no's. One and a couple yeses, no's. Nope. Okay, so most of you are not doing that. Okay, interesting, cool. Great. Someone said this is all new. Good. I'm glad. I'm hoping that you find some new information. So let's talk about the vagina gut pregnancy axis, because if you're working with women, you're probably working with women who at some point are going to become pregnant. Or if you don't work with women, you probably have friends, colleagues, and family who you know, or someone you know. I'm sure you know somebody right now who is pregnant. And so how does this conversation evolve into the pregnancy world? So we know that the maternal environment, the maternal gut and the health of the gut of the mom is very influential on the infant's microbiome and the development of the infant's microbiome, as well as the infant's immune system, as well as the breast milk. So the mom's gut, the health of the levels of inflammation and inflammatory cytokines and the health of the microbes that are there will also influence the composition of the breast milk. And if a mom has a lot of dysbiosis and inflammation during gestation, then that can lead to certain immunological problems down the road for the baby and for the offspring. And I meant to mention this earlier, you'll see little asterisks, for example, here talking about the immune system. If there's an asterisk, it means that at the very end, not part of this conversation we're having right now live, but as part of the slide deck that you will receive, I have a lot of supplementary slides that go into a little bit more detail. I didn't want to make this a 3-hour webinar, which it could be. So in order to be mindful of time, there are some asterisks. And so that's one of the things with this. So if a mom has gut dysbiosis, that's going to lead to more inflammation, more pro-inflammatory cytokines, and that's going to disrupt that T regulatory system of the immune system. And if that happens in utero, then that can eventually lead to an inappropriate immune response in the offspring. And I'm going to show you a clinical study, a trial on a particular probiotic later on in the presentation that illustrates this with some of the immunological effects after the baby had grown up a few years. Now, if any of you have worked with a woman who has ever gone through a miscarriage, you know that miscarriage is probably one of the most emotionally just devastating things that a woman can go through. And it's one of the big fears when somebody first gets pregnant is, am I going to miscarry? It's always, it's one of those things. It doesn't matter if you've had a miscarriage before, if it's your first pregnancy. That's the thing. That's why everyone waits until after the first trimester to announce it, because of this sort of initial time frame that this can happen. And so that there can be a very emotional involvement with this. And I'm not here to say that the vaginal tract or fixing the vaginal tract is going to be the end all be all cure for anyone or is going to prevent someone having a miscarriage. But what I am saying is that one of the worst things you can say to a woman who has gone through a miscarriage is, we don't know. We don't know why it happened. And there are going to be those situations where we don't know, because this is a big question mark in the fertility world. And there are many, many variables that can go into why someone might miscarry. But one of those things that I don't think is really recognized or talked enough about is the role of the vaginal microbiome in miscarriage. So if a woman has a predominantly lactobacilli environment in their vagina, that's going to do all of those protective things that we just talked about. It's going to inhibit those colonization of pathogens. It's going to help to balance the immune system. It's going to lessen that risk of pregnancy complications and possibly reduce that risk of miscarriage. Whereas if a woman has a lot of diversity, they don't have lactobacilli species, they've lost that protective mechanism that's going to prevent those pathogens from translocating up and potentially influencing the fetal membrane, and then also affecting the uterus and uterine contractions. And that can, in some cases, lead to miscarriage. So this is a research, if you're interested in this, and if you're wanting to learn more, and like I said, you'll have these slides. This is an article that goes through the role of the vaginal microbiome in miscarriage. And it was a review of 16 different clinical trials. And if you look at all of these clinical trials, there is a connection between the health and the balance of the microbiome in the woman, whether they have more pathogens like Gardnerella or Uroplasma, or whether they didn't have lactobacilli present. And there's this associated risk of miscarriage, and in some cases, second trimester miscarriage. So this is just, you'll have these slides so you can always go back and reference, but this was just a snapshot of just that association between miscarriage and pregnancy loss and the role that the microbiome in the vagina can play. Now, when it comes to things like preterm birth, there's also a connection. And women who, this was a clinical trial that looked at the community state type. So that's state type 3 and 4, which remember I said are the less, we don't want as many of those in our reproductive years. We don't want to have that state type 3 and 4. Those are considered less healthy. But if the woman had those community state types, then there was a significantly higher risk of emergency C-section. And then here, if women, what they found was that if they had more lactobacilli, then that tended to decrease that diversity, which is what we want. So we don't want a lot of diversity. And that helped to reduce that risk of preterm delivery. And then in this one, this was looking at the presence of Gardnerella, which is what will cause BV, and the setting of not having enough lactobacilli, and that can be a potential contributor to preterm labor. So absolutely, there's an association between a woman's vaginal health. So if you have women who are considering getting pregnant, or they are trying to conceive, or they're in the process of going through IVF, you absolutely want to be looking at the health of their vaginal microbiome. Now, I want to have a little note on vitamin D and how that enters into this conversation, because again, how many of you are testing vitamin D? How many of you have women or patients who are deficient in their vitamin D levels or insufficient? And vitamin D, what it does is, remember I said glucose and glycogen, that's the fuel source for these lactobacilli probiotics. That's what they love to feed off of in order to make these protective byproducts like lactic acid. What vitamin D will do is it inhibits this particular enzyme, the glycogen synthase kinase. And what that enzyme does is it inactivates glycogen. So vitamin D inhibits the inhibitor. So essentially what you're doing when you're supporting someone's vitamin D is you're supporting the levels of glycogen, because you prevent that enzyme from degrading that glucose. And so By inhibiting the inhibitor, you're allowing for those glycogen levels to be supported and to increase in the vaginal tract and therefore fuel and feed those lactobacilli. So if you have someone who has been struggling with their vaginal health, or if you're looking and they really don't have appropriate levels of lactobacilli, but maybe their estrogen levels are appropriate, look at their vitamin D, see if their vitamin D levels are appropriate. Now, vitamin D also has some associations with BV and affecting BV. So this was a trial, a case control trial that looked at the level of vitamin D and how did that lead to sort of the risk for having BV. And what they found was that those who were vitamin D deficient or vitamin D insufficient were between 3 and 4 times more likely to have BV than those who had normal levels. And this was another trial that was looking at BV and how that affected, vitamin D and how that was influential. And so the theory around this is that vitamin D, because we know it helps with the immune system in systemically, with autoimmune and, helping to ward away colds and flu. The other thing that vitamin D can do is it can help with the production of these antimicrobial peptides that are in the lysosomes or the cells of these macrophages and neutrophils. And so it could help with that pathogen removal mechanism. So definitely don't forget about vitamin D when you're working with women in health. And there are many other reasons why vitamin D is important in women's health and fertility, but specifically for this conversation, it can also influence the vaginal microbiome. So what would be some practical solutions? I just told you a bunch of science, gave you some theory, gave you some ideas, but what does that actually mean for you as a clinician when you have a patient coming to you this afternoon or tomorrow? So the first thing is we talked about testing community state types, and many of you said that you weren't looking at that. So if you're interested in starting to look at and investigate what someone's community state type is, and if it's making an influence or an impact on that woman's overall health, we do offer a vaginal health kit, which does utilize the same technology that our stool test, BioFX, looks at. And so it's whole genome sequencing. So we're looking at end-to-end DNA reads on those different microbes so that we can get a really accurate assessment of who is there in the vaginal tract. And as we said, we know that many of your patients are being influenced or affected by at least one of those dysbiosis risk factors that we were talking about. And if all we do is we just say, oh, you have a yeast infection, we treat the yeast infection, or oh, you have BV, let's give you antibiotics, or oh, you have a UTI. Yes, you have to give antibiotics in that case, but why? Why are they having these recurrent issues? That's looking at the overall health and resiliency of the microbiome. And the only way to really know what's going on in there is to do a functional microbiome analysis. So this is a sample report. This is actually 2 pages side by side. This is not like 1 page that you'll get. So on the first page, you'll get a read on just who's there, and you'll get to see, is this mostly, in this case, Lactobacillus crispatus? So this would translate to like a community state type 1, which is what we want. It also looks at various other lactobacilli species. It also looked at opportunistic pathogens like Uroplasma, Gardnerella, which in some cases, depending on who else is there in the vaginal environment, could be okay, could be kept in check. But if we don't have lactobacilli, are these having an opportunity to overgrow? We also have pathobionts, which are microbes that are going to come from the gut. So if you have a high number of these that are present, then you absolutely want to be thinking about the stool test maybe, or even just going and putting the person through a gut repair protocol or looking at their dysbiosis. So that would also be checked here. And then also we look at fungi and different Candida species. So who would be a candidate? Anyone who has any vaginal related conditions, looking at what their community state type is. Fertility, if someone is struggling with fertility and every other stone has been turned over and everyone's kind of scratching their heads, look at the vaginal community state type. Endometriosis and PCOS are definitely associated with different dysbiotic community state types. If they have recurrent UTIs or yeast infections and trying to conceive, for sure. If they want to be proactive, if they want to make sure that everything is in check before they are going through that process, then that may be also a candidate. And you may think of many other people besides this. This is just a short list of who could benefit. So that brings us to then what do you do? So we talked about what's the importance, how do you look for it, but then what do you do from a clinician standpoint in terms of intervention? And that's where probiotics can come in to play. And what's really exciting is that over the last 10 years or so, there has been this emerging growing body of research showing how probiotics taken orally can really affect the vaginal environment in a healthy way. And so we're going to go through some of those research trials here in a second. Let's start with one very specific, unique blend of lactobacilli called Astarte. So Astarte is a blend of 4 different strains. There's Lactobacillus cruciatus, Lactobacillus jensenii, gasseri, and rhamnosus. These were isolated from healthy pregnant women, so they are human-derived. Because in lactobacilli world, you have some that are human-derived and you have some that are dairy-derived. And the ones that are dairy-derived aren't as helpful for us as humans. And so we want to go with human-derived strains. And they are very resilient to digestion, actually. They have a unique enzyme in them that helps to moderate the pH level within the cell so that as they're going through the digestive tract, they're able to withstand the acidic stomach as well as bile salts and the acidic bile that they could get exposed to. So they are very resilient against digestion. And what they've been studied in several different trials. I'm going to show just a couple for you, but essentially they can help with the balance of the vagina from lactobacilli colonization. They can help with digestive and vaginal complaints. And so this was a double-blind randomized controlled trial that was looking at these strains and how they affected BV. And so this was just 2 weeks. It was a 2-week trial, and you had half of the women who took a placebo. So all they really got was just the metronidazole. So they just got the standard of care. And then you had the other half of women who received the standard of care plus the Astarte blend of the probiotics. And then they looked at various outcomes, diagnostic criteria for BV. They looked at discharge and odor. And what they found was that in the group that received the probiotics, 100% of women were no longer able to meet the markers for diagnosis of BV. So essentially we're BV free. Only 64% in the standard of care group who were not receiving probiotics, only 64% did not meet that criteria. So more women didn't meet the criteria for BV in the probiotic group. There was also a 200% reduction in that AMSIL score, which is the criteria for BV diagnosis. And then there was a significant reduction in discharge and odor. And so this was an interesting trial that was looking at how do these strains work with an antibiotic. And the theory around it was that these probiotics helped to get at the biofilms, because that's one thing with Gardnerella. It's very good about making and encloaking in a strong biofilm. So it gets resistant to those antibiotics, hence why there's a really high relapse rate. So the idea was that these probiotics helped to not only preserve the health of the vagina, but also helped to maybe break down those biofilms and allow for those antibiotics to be more effective. This was an open randomized trial. It was in pregnant women, and they essentially used the herpes virus infection as a model for vaginal dysbiosis. And you had some of the women who received the prenatal standard of care, and then you had some who received the probiotic, and then you had healthy women who did not have HVI, and they served as the control. And so this one was looking at candida overgrowth, vaginal discomfort. They also looked at other pathogens like strep, staph, Klebsiella, E. coli, Gardnerella, and then they looked at various pregnancy-related measures like preeclampsia, placental insufficiency. And what they found was that there was a 200% increase in lactobacilli colonization. There was a 58% decrease in women who had a pH above that 4.5. So you had many more women who the pH level was able to decrease through that production of lactic acid and become more of a healthy range for the pH. There was a significant reduction in vaginal itching. There was also a significant, increase in that hydrogen peroxide production. There's a decreased incidence of pathogens. There was a 50% decrease in placental insufficiency and a 50% decrease in preeclampsia, which, again, we're not making any claims here saying that these are going to prevent preeclampsia, but it was interesting that those in the probiotic group who received the probiotics had that kind of outcome in, again, sort of a question mark in the pregnancy world. And then also there was, again, that lowering of the pH through the production of that lactic acid. So just checking in to see if you guys are still awake and listening to me. Fun fact, who is this? Anybody have any guesses of who this person is? feel free to take a guess in the chat. And if anyone gets it, I'm going to be very impressed if you know who this is. No, not Mary Matt. Astarte, Linda, you get the gold star. This is Astarte. Astarte is actually, just a fun fact, back in the Mesopotamia Phoenician, way back when, she was the goddess of love, fertility, and war. And eventually through mythology, she ends up becoming Aphrodite. But how fun is that? I think that we have this really cool strain blend of lactobacilli named after this goddess of love, war, and fertility, who is essentially coming in and protecting the vagina and protecting our women. And anyway, I think that's just kind of fun. So be thinking, if you take the Astarte blend, you're channeling a goddess. So, but thank you. I'm glad you guys are all still awake. All right, science behind the strains. Let's go into a different strain called LA5. And this one is more specific to yeast and yeast overgrowth. So this was a 6-month crossover trial. So the women served as their own control. And so you had a group that started out with the placebo, and then you had a group that started out with the probiotic, and then they flip-flopped. Now, what was, I think, kind of interesting about this trial is that they started out with a much larger cohort to begin with, but at the time when they needed to flip-flop, those that were in the probiotic group, there was such a significant number of women who were feeling so much better that they just said that they were not going to go into the placebo group. So they had to be excluded. So the end result of the analysis ended up being a much smaller cohort than what they started with, because they had women who just decided that they didn't want to go into the placebo group because they were feeling so much better. So kind of a fun fact about this trial. But anyway, they were looking at Candida overgrowth, and they were looking at the recurrence of infection. And what they saw here was that there was a 30% reduction in discharge, a 66% reduction in burning, a 58% reduction in itching, and then a 57% reduction in dysuria. So lots of really beneficial outcomes from a symptom standpoint for those that were taking the probiotic. And now this was a triple-blinded randomized controlled trial. And what this one was looking at was, how does the probiotic stand up against standard of care, fluconazole? So this was comparing, are these probiotics as effective against Candida as the prescription version? So you had a group that received a placebo probiotic, so they just got sugar pills, but they did receive the fluconazole, 1 capsule of that. And then you had a group that received 30 days of the probiotic, and they received the placebo, just a sugar pill that represented the prescription. And then they looked at all these different symptoms. And what they found was that it was similar. Those in the probiotics were similar to that of the prescription. There was an 85% reduction in yeast infection and a 74% reduction in Candida colonization. So again, showing that these probiotics played a pretty significant role in helping with yeast overgrowth. Now, how many of you, just a yes or a no, or just tell me, how are you currently seeing pregnant women? Do you see a lot of pregnant women in your practices, or no pregnant women? Yes, yes, no, yes. Yeah, okay. So yeah, many. Okay, good. So hopefully this conversation is also relevant for you. Again, pregnant women, no one studies pregnant women. We don't, there's a lot of question marks with pregnancy. But I want to go through a few trials that were done in pregnant women using specific strains of probiotics, and I want to show you some outcomes. Let's talk about LGG. So LGG is a Lacticaceae bacillus rhamnosus. It is a very, very well-researched strain, and it has been studied in a lot of different areas, not just women's health, but immune health, gut health, IBD. Very, very well-researched strain. It's been used for years, over 30 years in the food and dietary supplement industry, and it's the world's most documented probiotic strain that has over 1,900 scientific publications and more than 250 clinical studies. So it's again, very well-researched strain, lots of really good data around it. And the one I want to highlight is one that was done in pregnant women. It was a 3-part clinical trial that looked at red and scaly skin. And so what they did here was, there were a group of women who received, there was a placebo group, and then there was a probiotic group. They received either 2 caps of placebo or the 2 caps of the LGG for about a month or so before the expected delivery. So it was around that 33 to 34, 36 week time frame was when they started this supplementation. Then they gave birth. Half of the moms continued the LGG, and then half of the infants were given the LGG directly, and that was done for 6 months, and then they stopped. So it was only a 6-month supplementary timeline, and then the additional 2 to 4 weeks during the preconception period. And so then they assessed what would happen afterwards. So they followed these babies for 2 years, for 4 years, and then for 7 years, they checked in. And they were looking at the different immunological outcomes. So allergy, food sensitivities, they looked at red and scaly skin. And what they found was that in those who were receiving the probiotics, 50% reduction at 2 years, 43% reduction by 4 years, and a 35% reduction by 7 years in those that received the probiotic. And it did not matter if it was given to the mom or if it was given to the baby. So whether the mom took it in pregnancy or whether it was given to the baby, it didn't matter. As long as they received the probiotic, there was this reduction in the red and scaly skin as the baby grew into that toddlerhood and young childhood. So again, talking about the immune system and how probiotics and how the health of the mom's gut can influence the health of the baby and their immune system long term, this is one of those trials that could suggest that there's that connection. Now, Istilose is not a lactobacilli, it's a bifido strain. It's a Bifidobacterium longum subspecies Infantis bifin O2. You know, we like to be very specific with our strains, but it was also, all of these are human derived. And so this is isolated from a baby, an infant, healthy infant. And it has a really unique way of utilizing HMOs, or those human milk oligosaccharides that are in the breast milk. But it can support the seeding of the infant microbiome in those first 1,000 days, which is the most critical time frame of influencing a baby's microbiome. And we always talk about the first 1,000 days, most important. And so it can help in that process. So what this trial was doing was it looked at, there was a mother's seeding group and then there was an infant seeding group. And so in the mom seeding group, moms took the probiotic again in that 2 to 4 week time frame before delivery, and then they delivered, and then they continued the probiotic for 28 days afterwards, and then they stopped, and there was a 2-week washout period where they were doing the analysis. And then in the infant group, the babies took the probiotics directly, again 28 days, and then there was a 2-week washout time frame where they stopped the supplementation and they did an analysis. And then they looked at the fecal samples, and what they found was that in those that were, the mom was taking it, there 100% of infants had the probiotic if they were given it directly. 30% of infants, if the mom was taking it, had the probiotic in their stool. And there was also, though, in those where the mom was taking it, there was a significant increase in butyrate in those babies that were taking it. The other interesting thing was that usually when we take a probiotic, one of the things we always talk about is you know, with some probiotics, you have to take them ongoing in order to continue to see the benefits or for them to show up in the stool. But in this case, what they saw was that in those babies who had the probiotic in their stool, instead of there being a decrease, there was actually an increase after the washout period. So even after stopping the supplementation, the probiotic strain increased in abundance during that washout timeframe. And so what that suggested is that this strain can do what's called engraftment potentially, which means that instead of just being transient, it can actually engraft and become part of the inherent microbiome and can become more established in the microbiome. And one of the things that we know about butyrate is that butyrate helps to educate the immune system and it helps to develop the gut epithelial system. So if we can increase butyrate in a baby, then we're helping to educate the immune system and we're helping to support the gut epithelial development. And so this is just a schematic that kind of walks through that. So the B. infantis, which is the Istilose, comes in, it secretes different metabolites, these specifically, which then cross-feed other probiotics that are butyrate secretors. And so this is how, by taking this probiotic, it can then cross-feed others and increase that butyrate production. And then butyrate then comes in and will support the gut epithelium and then support the immune system as well. And so again, critically important for babies during that developmental timeframe. And so that brings me to what we're absolutely so incredibly excited about, which is the launch of our first 2 women's health probiotics. We have a vaginal support or vaginal balance, and then we have pregnancy support. And they both contain the Astarte blend, so the goddess blend. They both have the Astarte, which is going to support the vaginal cavity and support the vaginal environment. But then the vaginal balance is more geared towards helping to support UTIs as well as yeast. So it's going to have some cranberry in there, and then the LA5. And then the pregnancy support is going to have the LGG and the istaloes. And one thing I do want to point out is that we put the study dose in our products. So what was done in the clinical trials to achieve those outcomes is what we're actually putting in our products so that we can have that correlation between those two. So these are the labels for the two products. So if you're thinking about who do I use these for, when do I use them, for our vaginal balance, we really think of this as sort of a women's one-a-day probiotic. It's, anyone who is just wanting to support their vaginal health, but also if they've had a history of antibiotic use, if they've had vaginal infections, whether it be yeast or BV, if they struggle with recurrent UTIs, if, again, they're preparing for preconception, or if they have run into different fertility struggles. And then postmenopausal women. So remember, if someone doesn't have enough estrogen, whether it be because of menopause or postpartum period, and if they are struggling with vaginal or urinary infections, then they could benefit from this product as well. Now, for our pregnancy support product, pregnant women who are at least in that 33 weeks pregnant, that was what the clinical trials were done with. If they are breastfeeding or pumping, and if they're just wanting to support their vaginal health during pregnancy, or if they have a family history of skin conditions and they're wanting to get ahead of it, they could benefit as well. Now, we also have some usage guides. So we have some new recommended usage guides that we have created. So again, some additional clinical support for you, and feel free to reach out to us if you would like these. But here's an example of our vaginal microbiome support for Candida. So if you have someone struggling with vaginal yeast infections, if someone is struggling with more bacterial overgrowth or certain bacterial imbalances in their vagina, then this would be our support. And then we have a pregnancy support protocol for women who are just wanting to optimize their health in pregnancy and their microbiome in pregnancy. We have some options there. So in summary, if hopefully at the end of this conversation, you are feeling, one, empowered. I hope that you feel very empowered in knowing this information if it is newer for you, because it means that for some of these women, if they've been told that we don't know why, then maybe this is something that could be done to be a why. It could be something that they can control, that you can control, that you can come in and intervene with. So I hope that you feel empowered to, if you're not already looking at the health of the vagina and the vaginal microbiome, looking at that as a piece of your assessment and as part of your toolkit. Because if we want to be successful with our clinical interventions, then we want to identify where the problem is and how can we affect the environment with which it's being allowed to proliferate. And so, again, using testing, using clinically studied probiotics that have shown their efficacy in the literature to optimize a woman's health can be very influential. These are some other upcoming educational events. We have our mini keynotes, part 2. If you missed out on part 1, that was January 15th. The recording should be up on our website as part of the educational section. It was a wonderful conversation with Dr. Annika Becca and Maureen Pickle, who is here today. Wonderful conversation, lots of clinical pearls. So really encourage you to, if you missed part 1, go back and listen to part 1. Part 2 is going to be coming up with Maureen. She'll be speaking on menopause and the microbiome on February 12th at 11 Central, 12 Eastern time. And then our clinical webinar with Jenny Olson, another one of our clinical science liaisons. She is putting together a fabulous webinar. I really encourage you guys to attend it because she's going to be putting lots of clinical pearls specific to yeast and fungal overgrowth in women and lots of good practical application points there. So really encourage you to attend these, ask your questions, and join us for those events coming up in February in about a month. I want your feedback on this presentation. Please scan this QR code. Give us your feedback. Tell us what you liked. What could we improve? Is this content interesting to you? Do you want more or less of certain things? This is how we then inform our educational experience and our sessions. So please, if you have a moment to give us your feedback, I would love to have your feedback. So. And thank you. That is all I have for you today. So I think we have about maybe 10 minutes or so where we can do some Q&As. And yes, is there a link to sign up for the February events? There is. JT, maybe.
Hey, actually, Alicia, I just shared 2 QR codes with you. One's for mini keynotes and one's for the clinical webinar. So
All right. Well, I will, before we send these out, I will put those QR codes into my presentation and that way you can have access to those registration links if you'd like, and you can get signed up for those webinars in the future. So, all right. Well, yeah, let me stop sharing here for just a second. I'll put it back up before the end, but happy to do some Q&A.
Quick announcement for those that joined late. The slides and the recording will be on the Microbiome Labs website within 48 hours. And also, if you could enter your questions in the Q&A so they don't get lost in the chat, that would be helpful. One question that we received is, how does bacteria get to the vaginal canal by taking it orally? What is the ideal response to this question when patients ask?
Yeah, so I'm gonna just go right back real quick to the real estate of where the proximity of, actually, hang on, let me, instead of doing that. It's the close proximity of the anal opening to the vaginal opening. And so the theory is that it has to do with the shedding of the feces. So as you're taking these probiotics, because they are resistant to digestion and because they are able to come in and establish and seed in the gut, then as a woman defecates, and especially as she delivers a baby, or just generally, as you shed these probiotics in the feces, then there's just a close proximity and it actually will get into the vagina. So that's the working theory in the literature. So I don't know that we really know 100%. Nobody really knows exactly how it happens, but that is what, if you look and if you read in the studies, that's what the theory is that's how it's happening. So we just know that those women who have higher lactobacilli in their gut, or if you're taking probiotics orally, that they just have higher lactobacilli in their vagina. And so that's how it colonizes.
Connie asks, is the vaginal balance meant to be taken on its own, or is it meant to be taken with the Megaspore biotic?
It can be either way. I think it just depends on your case. I think if you have someone who you're wanting to work on gut health in tandem specifically, and if Megaspore is part of your protocol, then absolutely you can take the two together. If you have someone who's maybe just gone through TGR, or if you've been working on their gut and you feel like now you want to focus mostly on their vaginal health, then you could take the vaginal balance on its own. So I think it just depends on your focus and your client, but yes, you can take the two together.
We also had a question about clarifying about biofilms and how someone would eliminate or manage biofilms.
Yeah, there's lots of different ways that you can manage biofilms, and there's different mechanisms of different products that you can use, and things like NAC can be used with biofilms. Like I said, the probiotics, the authors of that trial, the clinical study, there was a discussion in that write-up of, they theorized that because probiotics can also be efficient in helping to inhibit biofilms, and that was part of their working theory, was that these probiotics affected the biofilms within the Gardnerella, and that allowed for the therapy to be more efficient and effective than the group that was just receiving the antibiotics. They didn't have as high of a recovery rate as those that were taking the combination. So probiotics, HU58, another one of our products, is also effective at helping to prevent biofilms. But you can use, there's other things like NAC is another one. I mean, there's other combination products on the market. So I think there's many ways that you can affect a biofilm.
We had a question regarding insertion of the probiotic vaginally.
Yes, this is a common question that we get. So that would be an off-label use. We can't really say that, yes, that can be done, that it's not going to be part of our recommendations. However, if you as a provider choose to make that recommendation, there doesn't seem to be anything in the product that would be necessarily problematic. So if you chose to do that, that could be possible. So, but we are not going to recommend that. That's an off-label use.
Someone was just asking where they can find the protocols that you mentioned, and I was just referencing that they will be in the slide deck that they'll be able to access on microbiomelabs.com.
Yes, yes, they will be in the slide deck. Also, to reach out to your rep, we have a kind of a separate platform that you can access that has all of our protocols and recommended usage guides, more than just what I showed here today. So definitely reach out to your rep and ask for that if you don't already have access to our Frontify system. That's where we have all of our recommended usage guides. So feel free to get set up with that.
Someone asked if it was safe to use the probiotics rectally.
Rectally, probably, yeah. I mean, whether you're taking it orally or rectally, it's all going to the same place, so should be okay.
And then someone was also clarifying if it's not recommended to take the pregnancy probiotic before the 33-week mark.
Yeah, that was what it was a proof of concept study, and they just had to have they had to have a 4-week time window. So it was honestly, it was kind of an arbitrary time frame. There's nothing in there. It's just a blend of probiotics, and probiotics have a very good safety track record in pregnancy. And so there's no herbs, there's nothing in there that would be harmful. So if you had somebody who was wanting to take it before that 33-week, it would be fine to do that if you chose. Let's see, any other question? There's some in the chat.
The last question was regarding, it said, I understand that glucose and glycogen feed the good bacteria to thrive, but doesn't sugar also feed the bad bacteria to thrive?
A great question. And this is why some women, when they start birth control pills or they start hormone therapy, that sometimes they might get a flare in yeast, especially because, yes, you're right, glycogen and glucose also feed things like yeast. But remember, if someone has a healthy vaginal tract, they shouldn't have a lot of those opportunistic pathogens, and they shouldn't have a lot of yeast, because you have most of the real estate being taken up by those lactobacilli. So if you have someone who has a healthy vaginal microbiome with a proper more acidic pH, then that shouldn't be an issue. So one consideration would be if you have women who you are considering, like maybe they're perimenopause or they're postmenopause, or they are pregnant, they just gave birth and they're postpartum and that estrogen level hasn't recovered yet. So if you have a woman where there's a situation of low estrogen, where there's a possibility that their glycogen and their microbiome maybe have shifted, what you probably want to do is work on supporting the health of their vaginal tract and repopulating some of those lactobacilli to take up more of that real estate. Because if you were to then start them on hormone therapy or start them on like a birth control pill, then you could flare somebody with a yeast infection. So you want to work on that vaginal health first and then do the intervention if it's possible. It may not be possible in every clinical scenario, but if that is an opportunity that you have, or at least do it concurrently, then you lessen the likelihood of feeding some of those more opportunistic or pathogenic microbes. So, but yes, you are correct. We just want to try to make sure that that real estate is predominantly lactobacilli first.
Question says, just to confirm, the vaginal balance and megaspore can be taken at the same time each day.
Yes. Yeah. We have no evidence to suggest otherwise. Unlike, I know this question might be coming from our Zenbiome Dual, which is a bifido strain. That particular strain is a little bit different in terms of how it works with other probiotics. So we generally recommend that is spaced. That is not the case for these. We don't have to necessarily space them apart.
And just in case any of your questions got lost in the chat and weren't entered in Q&A, again, please reach out to your Microbiome Labs rep so we can make sure your questions get answered.
Let's see, I see somebody was asking about, are there strains in the pregnancy one that help produce folate? Not sure. I'd have to look to see if there's any in there that specifically will help produce folate. So, but I would say just supporting overall gut health, you'll be supporting strains that will help with that folate production. So, yeah. Let's see. I think I don't see any, oh. Can these probiotics assist in, maybe, I don't know, Maria, if you answer some of these, can these probiotics assist in supporting the moisture increase in the vagina for menopause since they balance the microbiome? Possibly. I mean, again, none of that has been specifically tested, but, you know, supporting the vaginal environment, possibly it could. One thing I also will say in terms of usage for these, so taking these probiotics, you're not going to change a menopausal hormone situation. You're not going to, you know, if someone is deficient in estrogen, unless they're taking estrogen replacement or hormone replacement, you're not going to change that. So some of these women, if they are in a low estrogen state, they may need the support on the product more long term than maybe, you know, a few months, which other women, if you're working on all the other dysbiosis risk factors, you're working on their diet, their lifestyle, their hygiene, and then you're giving them the probiotic and they have adequate levels of estrogen because they're in their reproductive years, then they may only need the product for a certain amount of time. But those that are not going to have that estrogen to support that glycogen and that fuel, then they probably will need it more long-term and ongoing. So just a little bit on the timing and duration of taking these probiotics. So, but anyway, well, I know I think those are all the questions, and I think we're at time, which is great. We were able to get through everything. But thank you all so much for coming and joining us live. We really appreciate you taking the time out of your busy schedules to listen to me talk for an hour. And the recording, as Maureen mentioned, if you missed it, it will be up along with the slides within 48 hours. So by the end of the week, you should have access to the recording and the slide decks. And feel free to join us next month for Maureen, who's brilliant in this. Women's health is her jam. So she is going to be a wealth of knowledge when she speaks in February, as well as Jenny. Again, really excited about her talk. So definitely, if you're wanting more on women's health, tune into those conversations. And we are here to support you. So thanks everyone for your time and have a wonderful rest of your day.